Once again, welcome to Medico Mello. This time we are going to see acute glomerulonephritis, or else known as the acute nephritic syndrome. Acute glomerulonephritis is a renal disease characterized by abrupt onset of hematuria, oliguria, edema and hypertension, and there is high chance of confusion of this AGN with nephrotic syndrome, so you must listen to this very carefully. If it is a mild disease, then it may go even undetected. If it is severe, then there is high chance of anemia, hypertensive encephalopathy, and it may also lead to heart failure due to volume overload. Let's see the etiology of acute glomerulonephritis, or this acute nephritic syndrome. It can be due to post-infectious causes like streptococcal, staphylococcal, pneumococcal, etc. and other agents are hepatitis B virus, hepatitis C virus, cytomegalovirus and Epstein-Barr virus. It can be a part of the systemic vasculitis like Hennes-Schönlein purpura, Wegener's granulomatosis, etc. And other types are membranous glomerulonephritis, IgA nephropathy, lupus nephritis seen in SLE. The first and foremost, the most common type is the post-streptococcal glomerulonephritis. The agent is group A beta hemolytic streptococci. It is seen after a streptococcal infection of the throat or the skin, and this proceeds by 1 to 4 weeks. Only a few strains are nephrogenic. Type 4 and 12 causes pharyngitis. Type 49 causes pyoderma. Let's look out the pathogenesis. Initially, there is enlarged, ischemic and narrowed capillary loops, and that causes the glomeruli to become bloodless. There is proliferation of mesangial cells and there is neutrophilic infiltration. And the granular deposits of IgA and complement C3 along the capillary walls are seen in the renal biopsy. There is deposits or humps on the subepithelial side of the glomerular basement membrane. Let's see the clinical features. It is more seen at school age and that even more common in boys. It can cause a rapid puffiness around the eyes associated with pedal edema, and there is cola-colored urine due to hematuria, but it may not persist more than 1 to 2 weeks. And the degree of the oliguria is directly proportional to the severity of the disease. But note this point. Anuria is uncommon. Hypertension in more than half of the patients results with decrease in the edema. What are the atypical presentations? There can be convulsions due to hypertensive encephalopathy. There can be left ventricular failure and pulmonary edema due to hypervolemia. It can cause acute kidney injury and it can also lead to nephrotic syndrome. Next, the lab findings or the investigations. The urine protein will be 1 to 2 plus with red cells. There can be RBCs. There can be granular casts in the urine. If there are WBCs in the urine, then it is suggestive of inflammation, but not of an UTI. There is hemodilatation, and that can cause normocytic, normochromic anemia. The ESR is very high. The blood levels of urea and creatinine are very high. It is more seen in the renal impairment. Hyponatremia and hyperkalemia are seen, with continuing oliguria. In normal kidney, it tries to excrete the potassium and reabsorb the sodium, but as the kidney is impaired, there is reduced resorption of the sodium and reduced excretion of the potassium, leading to reduced sodium levels and accumulation of the potassium in the body. In the chest X-ray, we can see there are vascular markings which is suggestive of hypervolemia, and it may also show lung edema if it is present. And anti-streptolysin or titers are very high. Anti-DNase B levels are high in streptococcal skin infections, and these titers reduce with 4 to 8 weeks. Complement 3 levels are low in 90% of the patients, and it becomes normal by 8 to 12 weeks. If persistent low levels of C3, then it may be other forms of glomerulonephritis. Regarding the management, if there is only mild oliguria with normal blood pressure, then we can go for home management with BP monitoring and diet control. Regarding the antibiotics like penicillin, it can be given only if there is any active pharyngitis or pyoderma, or else there is no use of antibiotics as there is only immunoglobulins and complements are acting on the body, and there is no organisms alive for the antibiotics to act. Regarding the diet, we have to reduce the sodium, potassium and the fluid intake. Overhydration may lead to hypertension or even left ventricular failure. Next, we have to give diuretics. In case of any moderate edema, then oral furosemide can be given, and this edema decreases with the return of the renal function. If there is any severe pulmonary edema, then we have to give IV furosemide. Management of hypertension is very important. If it is a mild one, then it can be prevented with salt and water restriction. In case of moderate to severe hypertension, we have to give medications for that like amlodipine, nifedipine, diuretics, labetalol, etc. We should not give beta blockers and AC inhibitors because they can cause hyperkalemia. Regarding the outcomes and the prognosis, there is excellent prognosis in childhood days. Many symptoms resolve, like in the first week there is loss of edema and there is reduction of the blood pressure. In the second week, gross hematuria and significant proteinuria decreases, and in 2 to 3 weeks the hypertension is relieved. But the patients with acute glomerulonephritis of non-streptococcal etiology, the results and the prognosis are variable and there is unpredictable outcome. As part of the investigations, we have to do renal biopsy, and let's see which are the indications for the renal biopsy. First of all, if there is any systemic feature like fever, rash, joint pain, heart diseases, etc., which can be due to some other diseases like acute rheumatic fever or SLE-like conditions, etc. Absence of serological evidence of the streptococcus infection, like if there is normal levels of C3. We are expecting very low levels of C3 in case of a pure AGN due to PSG and post-streptococcal infection. If there is mixed glomerulonephritis and nephrotic syndrome features, and the fourth indication is very high levels of urea. Fifth one is if there is any delayed resolution like persistent gross hematuria, nephrotic range proteinuria, very low C3 levels, and if there is persistent proteinuria for more than 6 months. And the first type we have discussed as the post-streptococcal glomerulonephritis. The second type is crescentic glomerulonephritis, which is a type of RPGN, that is the rapidly progressing glomerulonephritis. Chiefly, it is divided into 3. It can be immune complex crescentic glomerulonephritis, it can be post-immune crescentic glomerulonephritis, or the third one, anti-glomerular basement membrane glomerulonephritis. Here, the treatment is steroids, cyclophosphamide, etc. The third one is henoch-Schönlein purpura nephritis. It is the most common vasculitis seen in children. Here, there is very high levels of serum immunoglobulin A, and there is mesangial deposition of IgA. The treatment is again steroids, azathioprine, etc. And fourth one is the IgA nephropathy. Here, there is recurrent episodes of gross hematuria following an upper respiratory tract infection. Treatment is again steroids and other alkylating agents. Fifth one is lupus nephritis seen at SLE. There is remissions, relapses and progressive renal damage, which are the characteristic features. And the mortality is by infections and end-stage renal disease. And finally, there is C3 glomerulopathy. It is due to uncontrolled activation of the alternate complement pathway. And treatment is again steroids for immunosuppression. In all these cases, the mainstay of treatment are similar, like steroids, cyclophosphamide, azathioprine, alkylating agents, which are all focused on immunosuppression. And this is the end of our topic. This is your medicomello. Keep this in mind. Push yourself because no one else is going to do for you. Thank you for watching this video. Please like, share and subscribe.